First of all, thank you very much for having me here today. As you can see from my first slide, we are going to be talking about identifying and addressing health inequalities in urban settings, and of course, within the context of public-private partnerships, and in my case, in the context of cities changing diabetes, our example in particular. Now, as I begin, I'd like to, we oftentimes refer to statistics to inform us and to make better judgments about the size and scope of particular health challenges that we are trying to address. But in my case, I find it hard sometimes to distinguish between 1 million, 1 billion, and 1 trillion. It's just a lot. And so when we talk about diabetes, about the 437 million people across the globe living with diabetes, I rather like to think of it in terms of a group of people. And as a group, if diabetes were a country, it would be the third largest country in the world. So if this, I think, doesn't put it in perspective, I'm not sure I know what will. And of course, I could reiterate things that have been said already today about urban settings, but if you add to that the fact that 2 out of 3 people living with diabetes already live in cities, and by 2045 that will be 3 out of 4 people, you start to get a sense of the scope of the challenge that we face and the need to address this. In addition to that, to reiterate things already said today, we agree amongst us that cities are complex, in flux, and often changing, meaning that diverse drivers can affect illness and its lived experience. And indeed, as we all know, and this came up in the last session, Joe, when you mentioned the question of inequality, that when social environments are under stress, equalities aren't generally leveled; they're exaggerated. So the fact that the unequal nature of the way in which we, as it were, live with an illness is also potentially exacerbated in urban environments. We add to that another factor, which again, Joe, you mentioned right at the beginning, and that is that lifestyle illnesses are driven by significantly diverse factors and the need to cooperate across what in the last session were called silos of authority. And we realized that, in fact, that the health and all policies approach is in itself essential, but also an enormous challenge to us. Because it has consequences not only from the standpoint of getting people to cooperate, but also has consequences at the level of research. So, for example, in diabetes, we can pick any 1 or 2 or 3 of these. For each one of these all policies domains, we can find diabetes relevant risk factors. And when we look at them this way, we realize a couple of things. One is that from the standpoint of evidence, from what we know, we're oftentimes mixing apples and oranges, that some domains contain significant data for us to build upon. Others lack certain kinds of data, especially as that data relates to health and health impacts. And also, the challenge is that these clearly are not amenable to randomized control types research, because we're not looking at single causes, we're looking at compounding causes that exacerbate one another and that fuel one another in significant ways. So the challenge, setting aside all the other challenges that I'll refer to later on in my presentation, the challenges here are formidable from the standpoint of research. So in 2014, we, in conjunction with Novo Nordisk, invited us to join this new initiative called Cities Changing Diabetes with the Steno Diabetes Center, which has lots of experience in diabetes, both diabetes clinical care, but also in community health generally, to begin Cities Changing Diabetes. And we say here a first-of-its-kind partnership platform. I'm not going to say what kind of platform it is or why it's a first of its kind, because that's going to be up to Niels Lund tomorrow to to convey to you, and I don't have time for that. But I wanted to bring this up in my talk because it has important knock-on effects. For example, our expert working group for the United Nations Global Compact, which, as many of you know, monitors ethical and workplace practices in over 600 businesses, decided a few years ago, because all public-private partnerships are not alike, to develop a taxonomy that would allow us to see how businesses themselves become vulnerable as they relate to public engagement. And last year, the Economist Intelligence Unit helped to start the process of producing this taxonomy by producing a discussion paper for the UNGP that would get this ball rolling. All of which is to say that I think there's a lot of room in this conversation for talking about different kinds of businesses and what kinds of things they can do and what sorts of things are more challenging to them. So what I want to do here is I want to begin my actual talk about the research by emphasizing then that, first of all, that working across these different sectors to address the diabetes and related risk factors challenges is extremely challenging, but it's also challenging from the standpoint of its urgency, which is to say that the design of any research must begin not in the typical way in which we're usually assessed, where somebody takes a piece of research done in a university and then that gets scaled up to a policymaker recommendation. But basically, we have to be mapping, sharing, and acting coextensively. If we think about the fact that diabetes-related mortality and morbidity is scheduled to bankrupt the healthcare system of Mexico within the next 15 years, we realize that we have to move quickly indeed if we're going to reverse this trend. So the question then is, what kinds of research tools do we have? What can we use? Well, anybody who walks into a Novo Nordisk office is confronted by this, which is a good starting point. This is the rule of halves, and the reason it's in most offices in their foyer is because it actually is a constant reminder to us of how poorly we're doing in terms of treating NCDs generally and diabetes in particular. What the rule of halves says is for half of the 415 or 437, whichever statistic you take, million people in the world living with diabetes, only half of those people are diagnosed. Only half are diagnosed. Of that half, only half are receiving care. Of that half, only half are achieving their treatment targets. Of that half, only half are living with are living relatively stable lives without significant complications. Now, this is a really quite a devastating indictment against what we're doing to halt this epidemic. If you think about the fact that in the UK, for example, that diabetes-related mortality and morbidity, Diabetes UK says it costs about £10 billion annually. That's about 15% of the cost of direct care, healthcare in the UK. And on a good day, maybe that last half, this is just a lattice work. I mean, obviously the percentages are going to vary significantly depending on where you are, what city or what country. But that last half might be on a very good day, say 30%. It may be 40 if you really want to push it up. But even then, if you're spending $10 billion, that means only 4 billion or 3 billion of that's actually getting anywhere near its mark, meaning 6 to 7 of that is not. Okay, so the financial cost is extraordinary, not to mention the human cost, which I'll get to in a moment. So in Cities Changing Diabetes, what we've done is we started by doing these so-called rules of halves analyses in our cities, and you'll see some of the places that aren't marked in green are areas where we have only limited amount of data. So what this at least allows us to do is to try to develop some kind of a baseline to figure out where the gaps are, where we know things, where we don't know things, and then to try to see what we might learn comparatively across our sister cities. Again, Niels will talk about this tomorrow, but in the mere 5 years since we began, we now already have 20 city partners with the expectation of more than doubling that in the next 4 to 5 years. And the idea is to produce comparable databases so that we can actually compare our understanding and also share best practices. Now, how do we actually get the evidence? Well, let's drill down here a little bit because, sorry, I skipped a slide there. I'm not able to get this to go. I'm trying to go forward by one slide here. Okay, no, that's fine. Let me move on to the slide that did come up, because in my limited time, I want to focus on another element of the rule of halves, which I think it occurred to us as we started to do this research, and that is the way in which we define something as an illness. So if you look at that gray area in the middle, that's the area of the rule of halves. The bottom part is the only part of the rule of halves in which the social, cultural, environmental, psychological, whatever risk factors are not all that important, because this is only the bottom half, those people living without complications, for whom all those things really don't matter. So if you're in that group, it doesn't matter if you're rich or poor, you're well-educated or not, so you can put aside the social determinants literature. These people are doing pretty well. The problem is there just aren't that many of them, right? The middle ground is what we would call the ground of non-adherence. The top ground is actually purely social. We have to realize that people living with diabetes who don't know they're living with diabetes only have a social experience. They don't have a medical experience. So the only thing that's impacting their ability to live with that illness are the social factors that keep them from actually knowing what they're living with and trying to way of controlling that. Now, if we just add the major risk factor for diabetes, which is the third of us who are challenged by overweight. This final line here of people who achieve desired outcomes ends up being a thin line drawn across a desert of ignorance, which is to say you wouldn't even see that final line if you really had the 2 billion, the third of the world's population on the left, and that final part of the rule of halves on the right. Of course, that's where 90% of our literature comes from. We do literature searches, and we find that less than 10% of the literature on diabetes in any scientific search engine has to do with anything other than what you would find in an RCT or a clinical research. Okay, so we have a huge evidence gap here, and it's one that has to be dealt with very quickly. So to summarize, the problem's complex, locally diverse, difficult to identify and study, and leaves us with this massive evidence gap. So in order to address this, we began by developing a vulnerability assessment instrument. And what this instrument does, and I can talk about the details in the discussion if we want to, but just as an overview, we try to understand what are the environmental, social, psychological, and cultural risk factors for urban diabetes, who is most vulnerable to the negative effects of these risk factors, and how can those individuals and groups become less vulnerable. And you can read the definition of vulnerability we use there as I'm talking. But essentially what we do in the assessment process is we do three things. The first is we go to what we call the formal domain. We look at service utilizations patterns and barriers, who's served, who isn't served, short-term, long-term. Is this ongoing resources that people can have trust in? Are they short-term? We look at the community domain, and then we do something else. We ask people we know are vulnerable if they can lead us to someone else who's more vulnerable, and we go out and we find that person, okay? We try to characterize what are the barriers that keep people from being able to participate in their own behavior change and try to characterize them. And then what we try to do is we try to prototype these. So somebody with, say, certain blood glucose level, you can draw these lines across here any way you want between biological, social, geographical, and cultural factors and come up with relationships that are scalable, that are codable, and that actually can be brought up to larger data sets to tell us what percentages of a particular population in a particular place suffer from them. So far, we've done, this is actually old. We now have almost 2,000 hours of data that we are working to code. And the goal of this, as I conclude, I only have 1 minute left, is to understand how vulnerability emerges in a particular city, to identify new and measurable case definitions, we call them, of diabetes vulnerability, and to find ways of bringing that lived experience to the level of evidence. I don't have time to go into detail, but examples of our partner findings, just a few examples. In Houston, we found that the groups at highest risk weren't only poor people. They were also, as anyone who knows, Houston would suspect commuters, people living in gated communities, well-educated people. We also found that faith-based organizations were an extremely rich resource for helping people to manage their illnesses. In Shanghai, we found the stigma of middle-class families. The people concealed their diabetes problem for fear of losing jobs or even spouses. In Vancouver, we found that in food banks, the 850,000 people who rely on them were eating very, very unhealthily, leading the city to initiate on-site counseling. And in Copenhagen, as another example, we found our partners, I mean by we, our partners in those cities doing the research, that alienated middle-class men carry a very high unequal diabetes burden, by the way, in a country where healthcare is free to one and all and healthcare registration mandatory. Still massive inequality in terms of the experience. Goal of our program, to work with cities across the globe to reverse the diabetes epidemic. And Niels, I hope that you'll talk about bending the curve a little bit tomorrow. These are our toolkits. They're freely available, as are the guides for using them on the Cities Changing Diabetes website. And I invite you to contact us. Thank you very much indeed.
Thank you.